Good morning. I'm Dr. Allan Jaffe. I'm a professor of medicine and a professor of laboratory medicine and pathology at the Mayo Clinic in Rochester, Minnesota. And today we're going to talk about the use of more sensitive cardiac troponin assays to evaluate patients who have potential cardiotoxicity. I think it's an important topic, and it's one that's going to become more and more common because cardiotoxicity, in particular as it relates to cancer therapy, is going to become much more common. And I show you this first set of pictures just to sensitize you to some of the panoply of effects that you might in the long run see. These include arrhythmias, including QT prolongation, which can give you malignant ventricular arrhythmias that are life-threatening, heart failure, shown in the middle, thromboembolism as we begin to use more VEGF inhibitors, we begin to interdigitate with the thrombotic system, hypertension, renal toxicity with its secondary effects, all of which can lead to acute angina and or myocardial infarction. To give you some more substantive examples, if indeed you begin to develop heart failure, the frequency of supraventricular arrhythmias will become much more common. Atrial fibrillation, for example, is almost always a manifestation of heart failure of one sort. Similarly, there are a variety of agents shown at the bottom that can cause QT prolongation, which can cause these malignant arrhythmias called torsades de pointe, which are life-threatening malignant ventricular arrhythmias, and there are a variety of drug interactions that facilitate these types of arrhythmias. In addition, some of the anti-metabolic agents, the most common 5-FU, can cause coronary vasoconstriction, and that's the reason why the Japanese in particular have presented multiple cases of ST segment elevation, transient albeit, that is associated with cardiac toxicity and probably is a direct effect on the coronary vasculature causing vasoconstriction. Finally, as we begin to interdigitate and cause thrombotic processes, as you can see, all of the anti-VEGF analogs are prone to cause thrombotic complications, which, as most of you know, are the proximate cause of acute myocardial infarction in most instances. The heart failure area is one that really has gotten the most attention, and it therefore serves as the paradigm to begin to discuss how we're going to evaluate patients. But I would call your attention to the fact that this is the tip of the iceberg, and that with time, this interdigitation between cardiology and chemotherapy is going to become greater because of what I just showed you. If one begins to look, although this slide says that heart failure is 2 to 10%, depending upon the agent, I'm going to make the argument that if one really begins to follow patients long-term, based on the work of Lipschitz and colleagues, as I'll show you in a couple of minutes, that the frequency of cardiotoxicity is going to become even greater over time. And this has been stimulated really by the ability to follow children who receive chemotherapy. And in point of fact, as indicated by the title of this article and the sentence I've culled out from it, this is an increasing group of patients. In regard to some of the specific data, and I've underlined some of it here for you to see, more than half of all patients, young patients who receive anthracyclines, which is about 60,000, have some cardiac abnormality. And 5% or so have been thought to develop congestive heart failure. Now, I would argue that in particularly as you add comorbidities with life, that's probably a conservative number. And so, and it may well be that this is even greater as time goes on, as suggested by these authors. One looks the same thing if one looks at cardiovascular comorbidities in this study, an 8-fold increase in survivor of childhood cancer. Now, some of this may have to do with techniques that we're now sensitive to involving the heart, such as radiation therapy and the like. But again, there are going to be other more aggressive forms of chemotherapy to take the place of those cardiotoxic insults. This is simply, again, another example looking at testicular cancer, again, showing the increased risk for cardiovascular events that's accompanied by the mere treatment, to say nothing of the fact that many of these people may have cardiovascular comorbidities. Now, this whole field was really stimulated by an FDA investigator named Herman, who in this manuscript began to look at patients with troponin and asked the question whether or not patients who were receiving anthracyclines had elevations. And here's his original data. He sampled at 1, 4, 8, 24, and 48 hours, just in 10 patients, utilizing a very early, relatively insensitive assay. And at the end, we'll talk about the interdigitation of very high sensitive assays, which will give us a lot better information, but will also cause some real issues in regard to how we interpret those and how we use them going forward. But what Herman described for the first time was the fact that there was a signal of cardiac damage, which is what an elevated troponin means in patients who were receiving anthracyclines. He went further and he used anthracyclines in experimental animals, and showed there was disruption of the cytoplasmic vacuoles and myofibrillar disruption, as shown in this slide, and went on to document the fact that these elevations in troponin, as opposed to being related to some non-specific phenomena, because at the time we really were not as astute to all of the meanings of elevated troponin, really did reflect damage to myocytes. And he showed over time in a series of studies, not published in the most prestigious of the journals, that treated patients compared to controls tended to have higher levels of cardiac troponin over time. Now, this whole area was ripe for investigation, and a young investigator in Milan, Daniela Cardinale, really deserves the credit for finding this phenomena and really beginning to look at it clinically with the idea of both how to document it and how to treat it. And her work is really seminal, and we'll go through a little bit of it at present. She looked at a group of men and women who were receiving potentially cardiotoxic chemotherapy. This was not a pure group at the time. There were a variety of different protocols used and different diseases. But what she was able to show, again utilizing a relatively insensitive assay, was that those individuals who had elevated troponins were about a third of the population. Importantly, if one looked at that population, those were the individuals, not surprisingly, if you have damage to your myocardium, the likelihood of developing a reduced ejection fraction, which is a surrogate for cardiac performance, is substantial. And note, early on, we're not talking about drops that normally people who are giving chemotherapy are sensitive to. We often wait until there are very, very marked drops, but these are substantial drops of 10 and 12 and 15 ejection fraction points. And what they do is, as I'll show you in a couple of minutes, is presage the development of an increasing degree of LV abnormality. These reductions in ejection fraction were also followed by changes in left ventricular volume. This is not unexpected. What happens is that when you damage the heart and reduce ejection fraction, the heart increases its volume to maintain stroke volume, and one ends up with an increased volume. Now, in truth, if one begins to look at the cardiovascular literature, ejection fraction is not nearly as good a surrogate for long-term comorbidity as are LV volumes, which are much more sensitive and much more associated with adverse effects over time. And as you can see here, even if you're not impressed by the degree to which the ejection fraction fell, the volumes are markedly increased. And they're increased at the level where when we do studies looking at patients post-myocardial infarction or post other insults that affect the myocardium, are associated with quite an adverse prognosis. And there was a relationship, albeit rough, between the magnitude, utilizing a Spearman correlation, of the troponin elevations and the ejection fraction. And Daniele then went beyond that to look at another group and again asked the question whether or not there was a consistent pattern. And as you might expect, there were some individuals who had transient elevations, some who had none, and some who had a large number and persistent elevations. And again, not surprisingly, if one counts MACE, which is then and the components of that are listed on the left: sudden death, cardiac death, pulmonary edema, heart failure, a reduction in left ventricular ejection fraction by 25%, life-threatening arrhythmias, and conduction disturbances. You can see that there was a very high incidence in the individuals who had elevated troponins, an intermediate incidence in those who had transient elevations that were no longer detected, and very, very good response in those who had normal troponins. And she suggested the following risk stratification algorithm based on monitoring troponins over time. Now, because there were indications in experimental models that cardiotoxicity associated with anthracyclines might be related to oxidative stress, and given we knew at the time that ACE inhibitors were inhibitors of oxidative stress, after some initial studies that were done in hamster models suggesting that ACE inhibitors inhibited the cardiotoxicity, Dr. Cardinale tried this in patients. What she did was to look at patients who had early cardiotoxicity. If indeed of the 114 patients you had an elevated troponin, which is about a quarter of that group, then you were randomized to either receive enalapril or controls, and you were then followed. This was started a month after high-dose chemotherapy. The endpoint is shown here, which is the number of patients whose ejection fraction decreased by more than 10 percentage points, if we're less than 50. In the ACE inhibitor group, this was totally ablated. In controls, it was 43%. And if you look at the data related to troponin, there were elevations in troponin in the control subjects that persisted as chemotherapy was continued to be administered, whereas in the individuals who received the ACE inhibitors, there was reduction in the amount of troponin that was released, and if one looked with that, preservation of cardiac function. In terms of secondary endpoints, in terms of other issues that were related, they were relatively sparse, but heart failure, not surprisingly, and some arrhythmias were quite common. Now, at this point in time, one could make an argument that perhaps everybody receiving anthracycline should be put on an ACE inhibitor to inhibit oxidative stress. But I gather from my colleagues in oncology that oxidative stress may be part of the mechanism for chemotherapy. So it is not, we're not yet at the point, based on the science as I understand it, for us to simply advocate that everybody go on an ACE inhibitor. Not only that, ACE inhibitors have their own toxicity. They have some renal toxicity that can be associated. There's a unusual but obviously small percentage of individuals who have allergic reactions, rashes, and the like. So we're not ready to simply say treat everybody with ACE inhibitors. If one looks at trastuzumab as well, and Dr. Cardinale next turned her attention to this, and you look, you can see that trastuzumab also caused reduction in ejection fraction, that some patients had that resolve with the discontinuation or over time after therapy. And you can see there was a variety of times when this occurred, but it was often early during treatment. And part of the confounds of this that need to be investigated still further is the fact that, as the oncologists know very, very well, the vast majority of patients in these trials really had received anthracyclines first and then trastuzumab. What I think is important, however, is if one looks at the characteristics of patients who didn't recover, and I wouldn't focus on this slide because it simply says that the patients who didn't recover were worse off, but the most important part about it was that those individuals usually were the ones who had elevated troponins, and that there was some transient dysfunction when it was not associated with the elevated troponin. It was not associated usually with the persistence of cardiovascular toxicity, including the tabulation, which I show you here, which simply tabulates the number of toxicities and the number of events that occurred in each of the groups, those with and without an elevated troponin. Well, those studies were done with contemporary assays, some of which are still in use today, but they are relatively insensitive compared to the assays that are coming, and they're coming soon. As a matter of fact, high sensitivity assays are available now in almost all parts of the world, with the exception of the United States, where the FDA has not yet approved them. And in fairness to the FDA, they've not yet been submitted to the FDA, but they should be soon. And to give you some idea of what high sensitivity will mean, shown on this next slide. If you look at the number of normal subjects that are detected by any given assay, you can see the conventional assays are shown here in the middle in this study by Fred Apple, which I've reconfigured to make it, I think, clearer. In the brownish sort of area, you can see that most assays don't detect very many, if any, normal subjects to give us a number. Point of care assays are similar, and in point of fact, many would suggest that the point of care assays are exaggerated by this analysis at the bottom. The so-called high sensitivity assays, you can see, depending upon which one you pick, detect somewhere from 80 to 100% of normal subjects. Now, that doesn't mean those people are abnormal. What it really means is that there's simply a number attached, and it's one way of looking at sensitivity. Please note that originally we thought that the Roche high sensitivity troponin T assay detected 50% or more such patients, but subsequent analysis, and these results were generated by the companies, so this was not a function of who did the evaluations. These were samples sent to companies, suggests that perhaps it doesn't meet this metric. And Dr. Apple has suggested that the metric for high sensitivity ought to be a 50% detection rate. So that what is called the high sensitivity troponin T assay, and that's well ensconced in the literature, and you'll see it, may indeed be a bit of an exaggeration. Please note there's an occasional conventional assay that does pretty well, but also note that for most, these high sensitivity assays are really a major leap in sensitivity. Now, they've already been used by Singulex, which has probably the most sensitive of these assays, to look at cardiotoxicity. And in point of fact, the pharmaceutical industry, I think quite wisely, has begun to use these to begin to screen experimental agents in animal models for cardiotoxicity. One needs to be careful in doing that because there is not homology in every animal species, and there are data now generated by Fred Apple for a group called HESI, which is a group of the safety consortium that works for the pharmaceutical industry, defining which assays tend to work for which animal species, because they do have different levels of homology. The epitopes for the assays are different. But using the high sensitivity assay, here's one example of what happens with hydralazine when given to rats at a dose of 25 milligrams per kilogram. Here's another one, and this really is sort of the poster child because of the controversy over the use of glitazone-type drugs. This looks at the increases in rosiglitazone at higher doses. So this is happening. It's happening in the pharmaceutical industry in fairly great proliferation, and they're starting to utilize this strategy to screen drugs because they'd rather know a cardiotoxicity is possible before the drug begins to be given to patients than after. Now, there are very few data using high sensitivity troponin in patients. Here's one example that is in the literature, and it suggests something that perhaps we should not be surprised about, and that is that a substantial number of patients, 19%, had a substantial elevation because in truth, although you don't know the numbers for this, I can tell you that the 99th percentile, or the cutoff values for women, are about 16 with this particular assay, and it's about 34 to 36 for men. So 45 is substantial elevation. And of these, in response to anthracycline, 54% who had an elevated troponin developed cardiotoxicity during follow-up. But there are going to be some real challenges in using this, and I think it's important before we start to emerge and start to say, how are we going to do this, that we understand those challenges. One challenge is there are going to be baseline elevations. And in truth, it may turn out that those baseline elevations are terribly important and prescient. Perhaps patients who have elevated baseline values, even if they're clinically not detected, have an underlying cardiac comorbidity that may make them much more prone to cardiotoxicity, and that's a very, very important issue that is presently being probed in several ongoing studies. Just one example. One looks at what happens with age and high sensitivity, or quote, high sensitivity troponin values. This utilizing what I told you was the maybe high sensitivity troponin T assay. You can see that with age, there are tremendous numbers of individuals that increase their values. The normal values here are 10 for men and 10 for women and 15 for men. to substantially high levels, and they represent, for the most part, as best we can tell, underlying comorbidities. That is to say, all of us, as we get a little bit older, and we could argue where that cut point is, are going to have some elevations in our troponin. Now, in truth, we can't simply say, all right, we're going to change the cutoff values that we need to expect in patients based on age, because in point of fact, there are substantial numbers of males and females of older age who've kept themselves in great shape and don't have elevations. So we're going to end up having to use a changing value, set of values, but looking to see whether or not there is a comorbidity to start with is going to be terribly important. This is simply another example of this, and this example simply takes a variety of subtle cardiovascular comorbidities, such as mild hypertension, mild changes in renal function, left ventricular hypertrophy, diastolic dysfunction, and suggests that the curves that we see utilizing, in this instance, the high sensitivity Siemens assay, is going to cause a mild shift in the numbers for high sensitivity troponin. So we're going to have to be sensitive to the starting point and get baseline samples. Number two, with high sensitivity samples and high sensitivity assays, we're going to have to be much better at making sure our samples are obtained in a good way. I can tell you, putting on my lab hat, that about 75% of the abnormal values that we see in the laboratory aren't related to the analytics of the testing, but are related to the sample handling. And here's one example. We get most of our samples in intensive care units from lines, and a large percentage of them from the ED from lines. If you do that and you get hemolysis, you can see in this example, you lower cardiac troponin T levels, you increase troponin I levels. This is an important distinction, and therefore, if you're going to obtain samples, what we're going to need to do is to make sure the samples are of good quality. There may be elevations that are due to chemotherapy, but there also is the possibility that individuals who are receiving chemotherapy could have cardiotoxicity of a variety of sorts. They could have underlying coronary artery disease. They're certainly prone to develop cardiomyopathies and all of the things that could happen to anybody else. So there's going to be a difficulty in distinguishing that, and sometimes these can be subtle. This is an example of a study that was done by Jim Januzzi at the Massachusetts General Hospital, and the purpose of the study was to try and look for coronary artery disease, and they then superimposed high sensitivity troponin values. And what they found, not surprisingly, was even if they didn't find that the patient had an acute coronary syndrome, that there were elevations of cardiac troponin, high sensitivity, in all of those individuals who had any sign or semblance of underlying coronary artery disease or comorbidities, such as diabetes, a history of LAD disease, regional wall motion abnormalities, but even more importantly, even if they had structural heart disease, that is to say, if they had left atrial enlargement, left ventricular enlargement, left ventricular hypertrophy, and a panoply of these, so that this is terribly important to understand that these can be subtle comorbidities and that we are going to need to learn how best and cost effectively to interrogate patients when we see elevations in high sensitivity troponins, and not simply assume that chemotherapy is the only thing that could cause such elevations. In point of fact, if one looks at patients, and this looks at a cohort of patients who were thought to have stable coronary artery disease, the higher the troponin, meaning the more ongoing cardiac damage there is, the worse patients do. And the consequence of that is that as soon as you see these elevations, whether it is due to something that is intrinsic to the patient, the chemotherapy, or both, because cardiomyopathic stimuli are additive one to the other, it should call for the need for intervention to evaluate why, because the prognosis in these individuals is adverse. And this is one example. It is a cohort of stable disease patients. Here is yet another utilizing a high sensitivity assay and showing that when you take patients with risk factors or underlying coronary disease, they splay out like this. And what's going to start to happen is that those of us who follow cardiovascular patients are going to start to adhere to this as well. So you're going to be superimposing whatever chemotherapy exists on whatever is the underlying cardiovascular substrate of your patient. It's going to turn out that these high sensitivity assays are going to be very helpful. Here's just one example of looking at patients who start out with heart failure. You can see just by deciles of cardiac troponin high sensitivity that you can predict both mortality and rehospitalizations. We could go on, but I won't, but there's going to be a tremendous amount of information coming out to lead to both diagnostic and prognostic information, as well as therapeutic interventions. Now, one of the things, and you've heard me talk about this already, that is very likely to be terribly important, the use of gender-specific cutoffs. This is simply a tabulation of the number of assays that have been used with high sensitivity, looking at gender-specific cutoffs, and the reality is that women have substantially lower values than men. Now, the diagnostic industry is not terribly happy about this. They would love there to be something simple, one cutoff, one magic number for individuals to remember, but it appears very likely that there are going to be two, one for men and one for women. We have in the situation of acute ischemic heart disease, I would argue, undertreated women often in large part because their troponins are frequently not elevated because their coronary artery disease is different. So that it is very likely in the chronic circumstance that the need will be for oncologists as well as cardiologists to keep in mind the need for gender-specific cutoffs in evaluating this so we don't underdiagnose women and concurrently overdiagnose men. Then there's going to be an issue of how we should treat these individuals. It's not at all clear, and there are sophisticated regimens that are now ongoing looking at ways of inhibiting cardiotoxicity that may be far better than ACE inhibitors, and we need to do the trials to make sure that whatever therapies we use do not inhibit the results of chemotherapy, which thus far have been excellent. And how do we monitor this? Well, we probably can monitor the progression of cardiotoxicity with high sensitivity troponins, but it's not going to be as easy as we thought because of the concomitant comorbidities that could occur. Patients who have those comorbidities have an underlying propensity to have their troponins go up. So if they have mild heart failure and it gets worse, they will have a higher elevation of their high sensitivity troponin. So this is going to take consistent serial measurements. And one of the issues that has occurred in the field from my perspective, and many people have challenged the ideas of cardinal, and I think the reason for that is that there's a tendency to get spotty sampling infrequently, add mix assays, and you can't follow serial samples if you add mix assays, and not interdigitate the information from the troponin with what's going on in the clinical history of the patient. We still don't know, although it's likely if we inhibit damage to myocytes that we will reduce the long-term effects of cardiotoxicity, so that as opposed to over time one having these marked increase that Lipschultz and colleagues have so elegantly documented, that will reduce long-term cardiotoxicity. But the number of long-term studies, with the exception of those in children, are very, very few and far between, are desperately needed, because it is still conceivable that although we blunt the cardiotoxicity, that some still exists that will be synergistic with other cardiotoxic circumstances, whether it is intrinsic to the patient as part of their disease, or to their or to the disease itself, or to the chemotherapy. It also may be, as we find more about other agents, that some of the other agents we use may interdigitate. So knowing this will be important. And there likely will be some surprises. This is an area where I think, in the absence of some degree of rigor and standardization that I would hope the field will come to, that the values will turn out to be very difficult to interpret. And I receive phone calls periodically from my colleagues who try and deal with these patients and say, well, it's in so-and-so center, and I don't know what assay they use, and they don't know what assay they use. So that there is the need for real molding of protocols and algorithms to look at this. It is my advocacy that if we do that, we'll end up with good results. If we don't, we'll have many, many more surprises. With that, I will close my formal remarks and simply say that this is happening now. We're starting to measure these things. There's groups starting to form chemotherapy clinics that have cardiovascular consultation associated with them. This, I think, is a good thing and will help patients in the long run, but high sensitivity will be here in the United States probably within a year. Maybe it will take a little longer. It's available in the rest of the world, and unless we start to learn about it, it's going to come as a confusion rather than what it ought to be, which is a way, an opportunity to really improve the care of patients who are receiving potentially cardiotoxic chemotherapy. With that, I'll take questions. They're in my question box, and I'll try and answer them in the order they have been received, and I'll read the question first. It says, are there studies using CPK isoenzymes instead of troponin or conventional troponin? There were attempts to look at chemotherapy toxicity with CK and CKMB, and those assays were insufficiently sensitive to detect cardiotoxicity. This was only unmasked with the greater sensitivity of the troponins. I have no more questions in the queue, but I'd be delighted if people would send some in if you have questions, because I think this is going to become an area where hopefully those of you who are listening are going to need to become much more expert. So I'll hold for just a couple of minutes and wait. Well, I think if there are no more questions, we'll just go to the last slide. And this is the way in which, for those of you who listen to this talk, can receive CME credits. Here is your link. and I thank you very much for listening. There's one more question that has just come in. I'll take it. What are the units? It's a good question. Thank you. And I'm glad it was asked. When standard troponins have been reported as nanograms per milliliter. If one goes to high sensitivity troponins, you end up with so many zeros that many of us were concerned that those zeros were going to eventually cost somebody their life by having somebody miss a zero. We were convinced of that when one of the recent articles on high sensitivity troponin in JAMA came out with all of the zeros in the wrong place. So those of us involved nationally and internationally have taken the tack, and I think this will happen, that we should be using whole numbers. So for example, when I use the number 10, that's 10 nanograms per liter. So that the change is at the end, instead of milliliters, it's liters, and that allows us to use whole numbers. That's a terribly important issue that people will have to get used to, for those of you who are used to the conventional troponin assays, where there are lots of zeros as we get more sensitive. Thank you very much, and with that, I'll leave you. I appreciate your attention.